Hi, I'm Mahesh Menon.
Hi, I'm Smriti Khanna, and welcome to another episode of our podcast, Living Well.
Today we have with us a very distinguished guest. I'll just introduce him to you. His name is Dr. Umesh Khanna, and I don't know if you've met before, but yeah,
Thanks, Mahesh.
thanks. Yeah.
Thanks.
So, sir is a fantastic practitioner, very well known in Mumbai, and I'm sure he's known all over the place in nephrology when it comes to his clinical practices, style of practice. And today we'll be having a conversation with him about nephrology and all things renal. So we'll first start with, of course, asking you, sir, about your journey into the world of private practice and nephrology and how that came about, sir.
Thanks so much. I think it's traditional to say that once you're invited for a podcast that I'm super excited to be here. But here I am wondering in what situation I've been caught up. All throughout my life, I've been questioning my daughter for everything she used to do. And here she's now going to
Questioning
question
you.
me about various things. I mean, this is a very airy feeling for me. I've never had this kind
No,
of
they say na
feeling.
sir, कलयुग है, बेटी बाप से सवाल पूछ रही है.
Yeah. And the other thing is, I've been taught English in Borivali in some small school, and I hear many podcasts of yours where the Queen's English also fades in the way I hear you people talking in
हाँ
English.
sir, we,
So
yeah.
बीच में मैं अगर हिंदी में आ गया तो don't
No
I
No,
mean
sir,
take it
you're
problem.
from
as
Mumbai, yaar. You're a
yeah,
Mumbai boy.
correct,
Oh, okay,
correct.
great.
So, I mean, I am excited, but that feeling is there that whether in 45 minutes I will be up to the mark as to why you have called me here. Anyway, jokes apart, I'm very, very happy to be here in this Living Well podcast. I have always liked this name you have
Thank you, sir.
chosen
Thanks, sir.
because, I mean, at my age, when I'm playing my second innings, I'm more interested in knowing ke living well for people of my age. If you all are going to focus and bring it to the attention, it's a great job done. And of course, it's a niche field of palliative care where you're talking of living well, not only in your early age, but even in your sunset years when you are how to handle people and make them live well. So, congratulations for bringing this into focus.
Thanks, sir. Thanks, sir.
My journey, I think you did one podcast in which that word serendipity came into it.
Correct,
Yes.
sir.
So
Yes,
my
sir.
journey also serendipitously I entered and became a nephrologist.
Okay.
In the place where I used to stay, it was the neighbors who would decide which field you will take, or the uncles and aunts. You
a
had
community
no
decision.
community decision. So you got good marks. You had to choose science. You
Huh.
took science and got scored. You had to take up medicine. In medicine, when you score good marks in MBBS, you got to enter as a straightforward system. You will enter MD medicine, and because you are first in your class, MD medicine will be under Dr. Acharya's unit. She is a nephrologist, so obviously you walk into the shoes of That's how you become a nephrologist.
Oh.
Become a nephrologist, staying in Borivali, start practice in Borivali. But who will call you a nephrologist? There is no dialysis unit. There are only 5 dialysis units when I started in 1985, and they were all in suburbs. When I tell somebody you have a kidney problem, he said, "ठीक है, हम Bombay जाएगा." Nobody considers Borivali as Mumbai.
Mumbai, yeah.
So you got to first convince them that Borivali is also Mumbai and we have the facilities here. How did I get my first dialysis unit? Didn't have money, couldn't put up or afford a dialysis center. And suddenly we get a call, and this is where I like NGOs. There was an NGO called Diwali Ben Mehta Charitable Trust who had 2 worn-out machines, and they said if you pay 500 rupees, we will give you 2. And of course, I kind of took the tempo myself, reached there, took out from the godowns those 2 dialysis machines, repaired them, and eventually, lo and behold, we had a dialysis unit in Borivali. And from there, the journey started.
First dialysis unit.
First dialysis unit in Borivali, and now people take you seriously that you are a nephrologist. So it was tough.
I'm sure.
In 1985?
This is 1985 and 1987, 2 years when partly you were in KM and partly here, and you started understanding whether you could do nephrology in the suburbs.
In the suburbs, yeah, because you are there's something like being too qualified for the
Yes. And I think this idea of this concept for better treatment you have to go to Mumbai.
Correct.
Yeah.
Mumbai was definitely not in Borivali. So this was one of the challenges we
Challenges.
faced. But once we had a dialysis setup, people took us seriously. And of course, in the beginning, you sit in the dialysis unit and examine the patient for an entire 4 hours of his dialysis, and that's where you bring in the confidence. From there, of course, we built many dialysis units. Faced various challenges because that time there was no Ayushman Bharat, no schemes where free dialysis was given. The national dialysis program was started much later on.
Okay.
So my challenge was, who would afford dialysis? Only 1% of the patients of kidney failure could afford dialysis, and therefore I was forced to set up something called a NGO-based charitable dialysis centers. Fortunately, we had a lot of philanthropists who came forward, and especially the Jain community, they were forthcoming in setting up dialysis machines. So not 1, 3, 5, I built up almost 17 dialysis centers in the city of Mumbai.
Oh, lovely.
Most of them were charitable.
Okay.
And the once upon a time it was known that Mumbai was the cheapest dialysis center.
Correct.
Because you could get dialysis for 100 rupees, 300 rupees, 500 rupees per session, and even today Mumbai is still the cheapest dialysis unit.
That's all funded by the
So
supported
NGOs.
by NGOs. Okay.
NGOs.
So they are part supported.
Partly support. So the cost of dialysis, if say today, is about 1,500, then the patient pays 700, 500, 900, and the rest is borne by the philanthropist. So there is a corpus which is built up, and from that corpus you could
They finance this.
So this model was very popular, and fortunately we could develop many such centers.
Correct.
The second challenge is, who will run the dialysis?
Correct.
So you need a setup where you have to have a technician, a dietitians, nurse. There are not many. So whoever was willing to come, we trained them, and therefore the training of dialysis technicians, nurses, and dietitians was another area which we had to undertake.
All this sounds very much like some of the challenges we have heard of in our palliative care community, where people wanting to start palliative care, either teams or setups, and struggling to find manpower, struggling to start, who will fund. All these sound like very similar challenges. I'm thinking of my home care NGO, the home care NGO that I used to work for, Rumila Palliative Care. And very similar.
And even those who will be like passing out from their post-graduation now, and or
and
so
want to start,
and probably they go to a smaller town, and they will face the same challenges, because just on the outskirts of say a major city, they will face these challenges, because and that's very inspiring to hear how you went through this, sir. And I'm sure there'll be a lot of challenges. And my specific question was, did you face any challenges from the medical community?
So medical community actually was keen on having a nephrologist on board, because their patients also would travel. Somebody who required dialysis in 1985 had to go to either Nanavati Hospital or Bombay Hospital. There were only 5 major corporate hospitals who had dialysis set up
in the city
of Mumbai. And the patients would have to travel till that. So they were more encouraging. They supported me. Again, as I said, the problem was funding, and therefore we set up our NGO called Mumbai Kidney Foundation in 2009. And that was initially meant to help patients financially. People did come forward, gave us some funds to support the dialysis. And from there on, we built up from the financial help. We went on to education, because as I said, I was facing the difficulties in getting technicians, nurses,
personnel.
So we set up a kind of academy where we used to train the dialysis technicians. There was a time when almost every dialysis unit somewhere would have passed through one of my centers, and then established his dialysis practice somewhere else with another nephrologist. So it was fun. Doing Mumbai Kidney Foundation's educational activities also.
All right. So the Mumbai Kidney Foundation was set up in which year, sir?
2009 on the World Kidney Day.
Correct.
And suddenly we realized that three friends of ours who were school friends, so we decided one day that let's do something for the kidney patients. And of course, the family also chipped in. And this Mumbai Kidney Foundation was mainly for help, financial, but then we ventured into public awareness. In fact, today we are making a lot of Instagram reels from Mumbai
Correct,
Kidney
correct. I see
Foundation,
that. It's
trying
so
to
active. Yes, yes.
yes, so that's a
Very-
part of public awareness also. Of course, as you grow old, your hair become gray. You shift from critical care onto prevention and awareness,
Yeah.
and that's a normal journey, I think, of everybody. And the dialysis training program, the dietitians training program, and the transplant coordinators, because it's a natural progression that everybody may not be doing well on dialysis, and a lot of patients would want to undergo transplant.
Transplants, yeah.
In any case, transplant is the best modality for young CKD patients and not so old CKD patients. So again, transplant coordinators were trained, and we set up a fund to try and help transplant patients financially if and when they require. Even today, we have a scheme in which if 8 to 10 lakhs is the cost, 4 to 5 lakhs is supported by NGOs from our side. So this is continuing even today.
And you have been more and more interested in preventive nephrology and community nephrology as
Yeah.
you talk about it. What is this community nephrology which you keep talking about?
Yeah, I think people write in their CV as to attachments to this hospital, that hospital, this teaching institute, and so on. And I simply write that I'm a family physician in nephrology. When you're a family physician in nephrology, you are basically talking of how to handle the nephrology issues in community. So the advantage we have is we understand the difficulties of not just kidney failure patients, but patients of different strata, from lower middle class to upper class. People who are unable to otherwise get hospitalized also come to us. And actually, before palliative care came into the scene, we as community nephrologists had to do part of the work of palliative care
Absolutely,
people
I'm
Yeah.
sure.
to decide how to handle their dialysis.
Yeah.
But
Absolutely.
the guidelines will talk of 3 times a week dialysis. A lot of nephrologists would frown upon patients who would not come for 3 times a week dialysis. But here is a patient who can afford only that much. In my initial days, there was a young girl of almost 35 years of age from a poor background, and we took her in a charitable dialysis unit. But even that much she could not afford.
Correct.
She would come only once a week dialysis. And we would continue to do her dialysis once a week without forcing her to either come for 2 to 3 times a week or don't come at all. This was actually the training we had received, that you should put patients 3 times a week, because that's the American guideline which has come to it. But there are patients in CKD patients who have a good urine output. So whatever be their creatinine, if their urine output is good, they don't fill up fluid in their system, and therefore they are not symptomatic of breathlessness and all. You could manage well on dialysis. 10 years we did her dialysis once a week.
Wow.
She was lucky to get a cadaver kidney in KM hospital.
Oh, wow.
She got transplanted and led a very normal life for years together. And we were so happy that we could manage her once a week and lead her there.
And-
So, yes, guidelines are important, but in community, you need to see the pocket, the cultural background, what they can afford.
Yeah.
And so on.
It was so inspiring. Had you just stuck to the guidelines and said you come 3 times, so you don't come at all, she would have been abandoned, and that you didn't do. So that's so.
So I think that's a lesson that community nephrology teaches you, that what today we hear of patient-centric approach,
Correct.
we were forced to go for patient-centric approach during our times, because he would come whenever he had symptoms, he would come for dialysis. This system only I had seen in my entire nephrology community, because we were accepting as to whenever you come for dialysis, we will dialyze you.
Yeah.
If we were very strict, they would have died. So this
That's
SOS
so powerful.
dialysis, this dialysis whenever they have symptoms, is an entity which is not given in books. at least during the times when palliative care did not exist. Today, I
Exist,
think,
yeah. I
as
want to come back to that when we talk a little bit
okay,
about
right,
palliative care
right,
and this SOS dialysis or this,
sure,
once in a few days
yeah,
dialysis. But the other thing I want to ask you is amongst your patients, as you said, not everybody is able to go in for a transplant. So there are a lot of patients who, for financial reasons or other reasons, end up being on long term dialysis. What are some of the problems in terms of symptoms they face or other problems that they face in which you feel that, okay, some additional help, some additional support they need?
yeah.
What kind of things do you see?
Right. So medical issues, I think all of you all would be knowing that as the number of years, the vintage of dialysis increases, they'll come back with a lot of restless leg syndrome, itching, bone pain, muscle pain, sleepless nights. And this is very common for long-term dialysis patients. One of the worst things is bone pains and renal osteodystrophy and difficulty in getting up from squatting position and so on. So that's something which is medical. The other areas is caregiver fatigue, which develops because these are people who are dependent on their family and all. Financial, caregiver issues, mental problems. Where would the next dialysis money come? How will I feed my children? What about the education of the children, looking after the spouse? And these issues add on to the burden of medical problems. So we always needed emotional support with their mental health problems,
Yeah.
and very few centers had a psychologist to take
Yeah.
care of them. The other area is nutrition. There is a lot of course today all these WhatsApp universities messing up with their nutrition problem, but earlier also there was a lot of emphasis given on protein restriction because we were trained by the Western books. And if you look at even today's diet, if you're a vegetarian in India, almost everybody is on a CKD diet. If you calculate the proteins, their protein intake.
Protein restricted
Yeah,
diet.
I mean that idea of protein restriction cannot be extrapolated to Indian vegetarian CKD patients.
Only dal eating.
Only that. So even dal they are stopping. They will say only green vegetables, dudhi and all those things. This patient has hardly any appetite. He is eating very little. He has what we call as diabetic gastropathy and difficulty in swallowing or appetite, and he has fullness. And on top of that, you're restricting everything. And with all due regards to dietitians, they have been trained to consider maida and bakery as poison. And so even if the patient asks them, कि मैं शाम को what do I have with tea, they don't allow poor fellow 1 or 2 biscuits also. So the
There are so
idea
many
of,
restrictions.
yeah, there are so many restrictions. So I think we need to be pragmatic about what diet to be given to these patients. Today, what I tell my patients, if they are having breathing difficulty or swelling, salt restriction, water restriction, because there is a fear of potassium, there is advice regarding potassium restriction. If you just handle these, in fact, you have to tell our patients to eat more proteins. Anyways, they are malnourished. So they will develop a lot of infections if they continue to be malnourished. So I think one message which should go out in the community is not to restrict proteins for dialysis patients. Allow them to eat everything except potassium containing items, that too in a large majority. Some patients will have normal potassium, we even permit them. So I think nutrition is something which is always a problem. The other thing is balancing the salt and water. Nobody takes salt seriously. They just restrict water and don't restrict salt, then they become thirsty, then they drink more water. The reverse is also true. If you restrict salt but don't restrict water, then a time comes when you become hyponatremic, your sodium level goes down, and then they become drowsy and weak.
Come
and
to
all that.
hospital.
So that balance of both salt and water restriction is important, and most of the sudden deaths early morning on the day of dialysis because of high potassium. So one needs to be a little more careful about potassium restricted diet. So diet is some area which is important.
Yeah. In fact, I remember when I earlier used to take rounds in the dialysis unit, I used to see this was something I ended up seeing on the faces of all the patients. They looked all of them looked depressed. There was, I felt a much, I don't actually know what is the incidence of anxiety or depression which is reported in CKD, but I feel it is probably underreported.
Yeah, it is.
Most dialysis patients are symptomatic, which is troubling them in some way or the other.
Sure.
I also want to ask you about how much do you feel these symptoms are actually addressed?
So there are two issues in that. One, a lot of nephrologists may not take everyday rounds to see them and identify them. It's you need a very good dialysis doctor. Like we all have a dialysis doctor in the team, and that person knows the intricacies of the family background, and
Correct.
they can
Yeah.
they have a day-to-day talking and conversation with them. So many patients have this underlying depression, and the problem we face is when you give them antidepressants, they become more drowsy.
Yeah.
And this is one of the challenges which we find it difficult. So that's why a counselor is also far more important to handle some of the depression episodes. So antidepressants have to be chosen carefully and given in quantities which you will have to slowly build it up. The same happens, you are a pain and palliative care people, that when they develop pain and even as a part of palliative care, when we start giving them medications, whether it is pregabalin or gabapentin or tramadol, we face more issues with CKD patients and dialysis patients, and you will really have to start in a smaller dose and build it up. And a combination of these painkillers will be far more dangerous,
Drowsiness inducing.
induce and all that. So they are walking a very tightrope. I mean, you have to handle their symptoms, but at the same time, you can't use the normal dose for other patients and titrate them well for dialysis.
Yeah, I think the first step is to identify, and as you said, a lot of times these symptoms are under the radar
Yeah.
because the focus, and I think that focus applies to all across the board. It's whether it is cancer, kidney issues, heart issues. The focus is on that particular thing, and that you say you look at the trees and you miss the forest.
Yeah.
So that kind of an approach happens, and so that's why I was really impressed to see how you went about, making a complete plan around your patients in terms of their care needs.
So I also want to now move a little bit towards more questions around palliative care. So
Related to the
those
kidney, yeah,
related
yeah.
to kidney. My first question is, when you see patients in your practice, agreed that palliative care is a relatively new concept for many senior nephrologists also, because you may not have even encountered them
Sure.
in practice. I think that one very interesting thing that has happened is, I think, apart from oncology, nephrology is one of the only subspecialties where there are guidelines about palliative care in kidney disease. A lot of the international guidelines have a separate subsection about withdrawal of dialysis, dialysis in elderly, pain and symptom management, those things. But in your routine clinical practice, when do you feel that, okay, I should involve a palliative care physician?
So two or three conditions. So one is, of course, I'm glad that you touched upon the idea of nephrology related palliative care management, and I was privy to attending one of the side meetings where in the main conference of palliative care there was a full one-day workshop on nephropalliative care, and fortunately there are few nephrologists who are very passionate about
Yeah.
this. In fact, in our Mumbai Kidney Foundation, we have a website called mkfacademy.com, and in which there is a subsection on palliative care in nephrology. And we have all the articles, debates, the YouTube videos, and all assembled in the form of a library in that. That's one of the work which Mumbai Kidney Foundation is doing. So palliative care subspecialty in nephrology is slowly picking up. Some of us were very passionate about it. The reason, as she pointed out, is not many nephrologists are in tune with the needs of palliative care. two areas. One, of course, in the critical care and IC situation,
Yeah.
Correct.
where it's very important to decide as to whether this patient should be put on dialysis with all his comorbidities, um, the chances of prognosis being poor, and a very elderly people. That's the time when to explain to the relatives, the visiting nephrologist doesn't get much time, and a palliative care person along with the nephrologist, when they work as a team, it helps the patient to take a call of the relatives. So the confusion of the relatives is one. So initiation of dialysis is one area where we need definitely help in those situations where you're not sure whether dialysis is going to help or not. So in doubtful cases, to initiate dialysis or not, that's one area. And here it's very important because in elderly, sicker class of patients or patients with comorbidities, the results of patients who are taken on dialysis and patients who are managed conservatively is not vastly different. Maybe the overall the lifespan may increase a bit, but the quality of life is not good. And at times, the relatives, even after they have initiated dialysis, they come back to us to find out whether we should really continue
Continue.
dialysis or not. So, one is to decide about initiating dialysis. The second area is, as I said, once they've started on dialysis and don't find too much of quality of life improvement, that's the time when they come back to you and ask whether I can stop dialysis or not, whether I can reduce dialysis or not, whether I can come as and when there is a need for dialysis or not. And these are very genuine questions which, unless you are empathetic or unless you are in tune with the reality of what the relatives and patient is facing, you might take a a black and white decision, and there are no binaries in this whole discussion with them. So you need to be pragmatic and understand there, which sometimes nephrologists lack, and people in palliative care are trained to give the right decision on that. And of course, the end of care um, time when it comes, when to put off the ventilator and so on. So that's about the sicker patients. In the patients who are on a very prolonged dialysis or long-term dialysis, again you need palliative care people, because there are a lot of symptom complexes which are best addressed with people who have been trained in it. And that's where again it's important, because the questions of family, caregiver fatigue, psychological issues, mental health, and symptom burden, that also is important. So we do need. Unfortunately, in my practice, I was fortunate when Smriti was there, but Hinduja snatched her away, and now I'm myself trying to double up as a palliative care.
So, sir, I'll just summarize the four interfaces between nephrology and palliative. The first is when there are long-term dialysis patients, because there are complex issues related to not just the dialysis, the symptom clusters, caregiver fatigue, and taking care of the family. The second situation is whether to start dialysis or not. The next one is dialysis has been started, but whether we need to continue it or not. And the last is when there is an extremely sick and dying patient in an end of life care scenario, what has to be done with the dialysis. These four major interfaces you said.
There was one little thing I wanted to elaborate on. You said that for some subsets of patients, dialysis they don't do too well. So one of them is elderly. By elderly, what age group would you say?
So again, elderly by definition, now since I am becoming older, my definition of this has changed. 5 years after my age, whatever beyond my age, that's the elderly. But
anytime 5 years after.
5 years after my age. But I think again, sicker patients, comorbidities, frailty, malnourishment, all those things would add up, and even in that situation, age may be a relative
So I think
reason.
it's more about physiological age rather
Yes,
than
than,
maybe the
How
chronological
sick they
age.
are to start
how
with.
sick they are. Because in US, the guideline is such that whatever be the case, you have to do hemodialysis. So we've come across the stories of patients who are carried by ambulance, stretcher, they are blind, they have amputations, LV function is barely 20%, and yet I think the guidelines force them to take
get
them
on
on
dialysis.
hemodialysis and so on, which maybe now the situation changing with palliative care being all over the place, including in US. Maybe they have changed some of these guidelines. But in India, I thought we should bring about this topic of how do you handle the elderly people
Yes.
with two or three new ideas brought in. One is home dialysis.
Yeah.
The other is dialysis when there are symptoms. And three is dialysis as per the needs of the patients or desire of the patient. Because ultimately, at that age, patient-centric care is what we've been now, pushing.
And this is for patients where we are focusing on the quality of life. Knowing that maybe this modality of dialysis, like lesser frequency and all that, may not actually correlate with their quantity of life or their number of years that they have lived. So once we take a decision that we are focusing on quality of life, we are focusing on comfort, that is when we think about all
So-
these things.
Because a lot of elderly who come in for dialysis, many times it's their children who are working, who are taking care of them, and there'll be a lot of guilt associated with the fact that if they're not able to take care of their parents, if the father says, I want to go in only once in 4 or 5 days, and they feel guilty, no, doctor has said twice. So that stress, that guilt, that fear, how will you reassure that? What can you say to reassure that
Sure.
family?
So again, this is an area where if you get a palliative care person together, then working in tandem with the palliative care people who are more used to handling the caregivers and the guilt and how to address that is important. Secondly, if that is not available, then you play that role and guide them. Okay, look, I understand that he needs 3 times a week dialysis. I also understand that his desire is just once a week or twice a week. Since he doesn't have too many symptoms, don't go by the book. Agree to what he wants. Ultimately, it's his life. So you do talk to them and you don't feel guilty. In fact, guilt is the last thing that should come to your mind. This is what we explain to the
To the
caregiver
family, yeah.
also. Okay, this is the way. And I always use the thing, if my father would desire this, I would accept his desire and go by it. The same advice I'm going to give it to you. And this statement that if my brother, my father, my brother, sister, my wife has this illness, I would manage like this, is what I have done in my life till now. And this has helped me in convincing the patient that yes, the decision they took was correct and there won't be any guilt. They do come back later on and thank me,
That's very
doctor.
sweet.
This was a good advice you gave. Otherwise, I would not have been able to take the decision. And of course, there are some patients who want dialysis till their 3 months down the line there is an engagement, or 5 months down the line there is a wedding. I want to attend the wedding. After that, I'm not interested. All those issues do come up, and you just listen to them and guide them according to their wishes. I think I have always practiced patient-centric.
So very the core of what you're saying is it has to be patient centered in this context. So sir, you mentioned three things. You mentioned the home dialysis part. So can you just tell a little more about it, sir?
Right. So home dialysis, the best thing is it is in the confines of their home, their environment, their loved ones, their family. He's chatting with his grandchild.
Correct.
He's sometimes, telling stories to the grandchild and all that, and continuing dialysis. So there are two types of home dialysis. In US, more of home hemodialysis. In India too, it is more of home hemodialysis. In some parts of Europe, in Thailand, Malaysia, Singapore, in these countries, CAPD or peritoneal dialysis. Our group, and I run Kidney Associates, a group of 7 nephrologists, and we are very, very centric on CAPD or peritoneal dialysis. Now, why we are more passionate about peritoneal dialysis? Because it's a slow dialysis, similar to what our natural kidneys do. You are doing it with peritoneal. It's more physiological. So anybody who has a ejection fraction which is less and who's likely to have low blood pressure on when he's put on hemodialysis, CAPD will
Poor
be
heart function,
poor
that
heart
means.
function. CAPD will be better. Similarly, people who have low blood pressure, CAPD is better. So it scores over peritoneal dialysis.
It
It is
scores
a
well.
home dialysis system, and it's almost equally effective.
So, if there's someone who's listening and they're not necessarily from a medical background, how would you tell this? Like you're explaining to a patient's relative about the two types of dialysis. One is from the. How do you explain it? Yeah.
So we basically tell them that you need an artificial kidney to manage the system wherein your own kidney is damaged. Now, when you take an artificial kidney, it's called hemodialysis, where there is an artificial filter which will do the job. The same filtration job can be done by your own abdominal blood vessels, because ultimately we tell them that it's a removal of toxins from blood to the tissues. So we actually show them on a laptop. We have a CAPD nurse who goes to their house, explains to them. They understand how the exchange of impurities occur. We make them visit a patient who is already doing a CAPD. The ambassador is the patient who is undergoing. So some people who have doubts whether they are able to, they would be able to do or not, based on the nephrologist saying, they agree when the patient.
See it happen in front.
And there are patients who have done both hemodialysis and CAPD, and they tell you that, boss, I was on hemodialysis, but I am on CAPD, and I swear I will not go back to hemodialysis. So there are some people who are very happy with CAPD. So we are a votary of peritoneal dialysis because it's a home-based system. It gives the same care. And again, if the patient desires to do less dialysis, he can do it. Instead of 3 times a week, 3 times a day, he can do it twice a day. Then there is what is called as automated peritoneal dialysis. If money is not a problem, daytime he's free, nighttime he just ties himself to the machine. The machine does his dialysis at night. He is sleeping, in the morning he's fresh, he can do his activities, and he's free. So CAPD and hemodialysis, both homebound treatment. Home care is being, at least right now in US, there is a movement towards home care. And they're pushing home care. Of course, they are doing more for hemo, but it's the same whether you do for home or PD. So I think we should all push.
How does home hemodialysis or home peritoneal dialysis so happens at home only? How do they then help in patients who are seeking more comfort? One is, you said yes, you are doing it in your house. Anything else which you think is there?
So there are 2-3 things. One, traveling to the center.
Yeah.
3 times a week.
Yeah.
Fixed timings.
Yeah.
A caregiver has to accompany them. Loss of job of the caregiver also.
Yeah.
Fatigue, sitting there, wasting, into inverted commas, his time. And that's one of the biggest reason. Second, it's a hospital setup. Next door, there is a pneumonia fellow who is being dialyzed. Another fellow, there is another bad infection. He's an ICU person who has recovered partly and is doing dialysis next door. So, and there are all kinds of patients. And one person who is very sick is going to depress you furthermore. If anything happens to the neighboring bed, he is also affected. So, home is where everybody likes being.
So, if I understand this correct, if I have to set up a home hemodialysis unit, there'll be a lot of modifications to be made to the house also, right? That is also a problem. Or
right. So these days there are the kidney companies or corporations who help in developing a home dialysis program. So they have center-based dialysis also and home-based dialysis. The moment you decide I want to have a home-based dialysis system, you contact 3-4 of these companies, any of them. They just come to inspect your place. They bring a portable RO system and a portable machine. You need very minimal modification. You don't have to do the entire house plumbing, and you don't have to purchase the dialysis machines and all. So they do come home, set up the home hemodialysis system. You pay a small deposit. The cost is a little more than hospital-based dialysis, but then it's in your comfort of your home. So setting up a home hemodialysis is not difficult. It's easy. Little more of an expense, that's all.
And what about setting up a CAPD?
CAPD program again. One day he has to go to the hospital to insert the catheter. In 24 hours time, he can go back to his house. The training is done by a CAPD nurse. It is done at home, and either the spouse or the family member gets trained. If the patient is pretty mobile and intelligent enough to look after the infection and sterility concerns, he can do it himself. So that's the difference between Western home dialysis and Indian home dialysis. Western home dialysis is patient himself does. Even cannulating the vessels, the patient does it
Wow.
himself.
Okay.
And CAPD also, the patient will do it himself. Here we are caregiver dependent or technician dependent. So this is sad part, but in fact, that's where the spouse or the caregiver.
But we also, you were saying that we end up reusing our PD machines, our peritoneal dialysis
Yeah,
machines.
so actually we have, again, we were talking Mumbai Kidney Foundation. So one of the areas we help is in setting up a home PD program. If the patient needs a free daytime, going to the office or job, or for whatever reasons, if he is keen on an automated PD system, then before he can purchase it, Mumbai Kidney Foundation uh, gives the machine to the patient. He tries it out, and I must thank Dr. Armida Fernandez, who has actually donated this machine to Mumbai Kidney Foundation, and because of that, so many patients are using it. In fact, if you're talking of critically ill patients, there are patients who are bleeding or post-operative, and you can't take them on hemodialysis. I have used the same machine of Dr. Armida Fernandez, who was donated to us, and gone to the ICU, used it for temporary dialysis. And actually this patient who would otherwise not have been able to tolerate hemodialysis, he comes out of it because you've tided the acute problem, basically because if he has a lot of uremia, infection, acidosis, if you look after that part for a couple of days with the help of peritoneal dialysis, he can come out of it and have a reasonably good life. So there is a good scope for peritoneal dialysis even in a ICU setting or a critical setting.
There was one question that I wanted to ask you. Like you told me about, like you said about trying to reduce the number of dialysis. How do you counsel families? Suppose there is a family, or there are families watching where their loved one wants to stop dialysis. What would you say to them?
So this is an area where you need a dialogue with the entire family. The patient is keen on stopping dialysis. The family generally is too confused to go by that decision, because for two reasons. One, they feel whether the patient's taking the right decision, or because he's too depressed and he wants to stop dialysis. And if he stops dialysis, what symptoms will he develop at home? As a caregiver, would they be able to handle, would they be able to see this situation and all? And herein, it's important for us to counsel the family members, tell them in advance, okay, what can happen. Now, if this patient is passing urine, we give them a lot of diuretics, helping them to pass more urine, and whatever fluid we are going to remove on dialysis, hoping that some part of it is taken care of by the urine output. The second is to tell them that you bring him to the hospital only when he becomes breathless. Otherwise, you go by his ideas of not doing dialysis. The role of palliative care is extremely important, because there would be a time when his symptom control will need sometimes opioids, or taking care of his breathlessness might need a little bit of morphine, or areas where symptom control is best handled by palliative care people. As nephrologists, we are not so well versed with handling these critical emergencies. But if you explain to the patient that these symptoms would be momentary and we have to take care of it with the help of palliative care team, and we will see to it that his terminal days are comfort care will be given. We will not be abandoning the patient. The main problem comes because some of the nephrologists, they are interested only if the patient wants to continue treatment in them. And after that, that feeling in the minds of patients should not come that he or she will be abandoned. So if you are hand-holding the patient till the end, then they understand and have confidence in this whole thing. So you need a team or yourself to handle them, including the terminal events which can occur. And of course, this is one area which I think most people don't face it because they are hospital bound, but in community,
Exactly, I was gonna say
when
that.
there is a time for death certificate issuing, you should be in a position to help them. Because that's an area which is extremely tricky, and a lot of people raise their hands up that I won't be able to give you the death certificate. So all that hand holding should be there till the end. So patients and the relatives should have confidence that they will be looked after.
That you are their doctor.
Yes.
That feeling, and I think that reflects from your experience, reflects from what you just said about being with your patients uh, forever, not abandoning your patients. So that's, and that also highlighted the second indication for dialysis in palliative care. This is like as needed.
As needed. I think this concept is not very popular. For whatever reason, our training has been to
Correct.
follow the guidelines, but otherwise, as needed dialysis, patients
For
can
symptom
really go ahead for a couple of months or more with as needed dialysis.
So it's a message for palliative care physicians also, because we can't just be absolute about things and say no dialysis, no internet.
Yeah.
You can
Yeah.
always focus on the
Yes.
very important message
Correct.
there.
Correct.
Yeah, as needed dialysis, I think, should become more prevalent if you have decided that the goal is not prolonging life but reducing the symptoms,
Yeah.
making
Improving the
the
quality
life
there.
comfortable, improving the quality.
So, the last question that I want to ask is what does living well mean to you?
Oh, so living well, of course, is I don't know whether it can be answered in a short well, but being Umesh Khanna continuously, according to me, is living well. I have been living well. God has been kind. For me, my professional life, my family life, my education, everything has been smooth and financial. So, being what I am today is good enough for me, and I have absolutely no desire to do something beyond what I'm doing. So, this for me is living well. I hope it continues it because with increasing lifespan, um, we are going to be burdened with a health span which may not follow the lifespan. And I'm hoping that my whatever meditation, yoga, physical exercise, whatever we have been doing, the nutrition part will continue to take me uh, to the gap between health span and lifespan will be narrower. As far as for anybody else, it may be different, but for me, living well is a combination of professional, family, financial, spiritual, emotional well-being, which is what I've achieved. So I'm quite happy.
Thank you, sir, for sharing this, because in your we asked this to everyone, and you're the first person who's used two words: health span and lifespan. So that's a beautiful concept. Uh, thank you, sir, for doing
Thank you
this
so
and
much.
for being part of this. And we wish you all the best with all your social media presence and the amount you're doing for education. It's very impressive, sir.
Yeah.
Thank you.
It's been really nice coming over here and sharing our thoughts, learning from y'all, and at the same time hoping that our listeners would also benefit from it. Yes, Mumbai Kidney Foundation, if you could follow, especially our Instagram handle,
Yes.
it might help us. We are again trying to increase our health span so that it matches the lifespan. This is what our new aim or goal is.
So we have to learn this from you. Now, in all our podcasts, we have never asked him to like, share, and subscribe to our own podcast. Sir comes in and he says, like, share, subscribe, Mumbai Kidney Foundation.
So man is
We're learning something
selfish.
from you.
Man is selfish, and I'm just showing it. I am
No,
also.
sir. Thank you.
Thank you
sir.
so much.